Hello, and thank you for joining the webinar today. My name is Dana Baker from Mayo Clinic, and just a quick introduction on myself. I've spent the majority of my career at Mayo Clinic in the benefits department, working on plan design, communication, and education. And I currently work with our Centers of Excellence program, supporting employers, TPAs, and payers to provide that high quality care for their members and their complex conditions. Before we dive into our webinar topic today, I wanted to share a bit about Mayo Clinic. Mayo Clinic is ranked #1 in the nation and holds more than #1 specialties rankings than any other hospital. We have a staff of over 75,000 employees, including physicians, and we're all salaried. And what this does is it creates the needs of the patient come first. And what that means is there's no incentives for doing anything other than finding the right diagnosis and the right treatment plan. Across the campuses, we have every single specialty that is known under one roof, which creates a collaboration with all the different specialties. For our time today, I will focus on social determinants of health and how they impact medical plans, and most importantly, your members. We'll cover why it matters to address these and how it impacts your employee population. Why now? What are the trends and why is this such a hot topic? How to identify your organization's data, solutions, and consider different types of solutions within use to create inclusive medical plans. Let's start with the definition and why this matters to your membership. Most of us know this, and the 5 kind of categories that social determinants of health fall into. Just kind of a brief introduction of what that looks like in case you haven't seen this. And it's, where people are born, where they work, live, age, income, access to food. These are all factors that impact health risk and outcomes. For today, we're going to focus on just a couple of these areas. So first is economic stability, healthcare access, and how that quality of access based on where those members live, and how those different things impact your population and your medical plan dollars. And then we're going to go through some strategies on how to improve your pool's plan design to address these. So considering the progress that's been made in medical care across the United States, despite that progress that has been made, we know that many population groups experience poor health conditions, poor outcomes because of the race or ethnic group, religion, financial situation, or because of where they live, such as a rural area. For example, in those rural areas, they're less likely to have access to high quality care, or they may completely delay that care, not just because they don't have access, but because it might not be the best quality. Or individuals with low income may delay care altogether until it's a catastrophic event, which we know really affects your plan dollars. So let's touch on a few examples of why this matters and how it directly impacts the income of the outcomes of your population. The first example, life expectancy. It varies by race and gender. So kind of quick statistics across the United States. Hispanics, for life expectancies for females, living up to over 84 years, and this is females born in 2015. But you look all the way down that for African Americans, their life expectancy is just over 78 years. For children from low-income families, they're more likely to have asthma. Black African Americans are more than 3 times as likely to die from an asthma-related event than white Americans. High blood pressure is more common and not as well controlled in Black and African Americans than Hispanic adults and white adults. For U.S. rural populations, what we spoke about before, they have a higher rate of death due to heart disease. And this is a couple of reasons. One is they're in a rural area and they don't have access to that care. The other is sometimes a cultural event where they're not seeking that care very often. They also have chronic lower respiratory conditions and are more common to have strokes in urban populations. While not all outcomes can be really directly addressed by plan design changes that we're going to go over today, there are some steps that you can do to make an impact. So going through the areas and kind of what you can do as a population and somebody that oversees a pool, there are 4 main reasons why this matters to you. One is your plan costs, and we hear that from employers and TPAs every day is, my plan costs, how can I control them? The social determinants of health affect 30 to 55% of health outcomes, which directly impacts your plan dollars. Number two, this type of addressing social determinants of health really supports your employers who you're covering under your pools, their DEI efforts, and improves their recruitment and retention strategies. And three, really most importantly, is the member impact, improving the outcomes of your members, your most valuable assets. And fourth, I put this here because we all know this is happening. We know what the last almost exactly 3 years ago has happened. So recovering from the delay of COVID's impact has been significant. As a healthcare organization, we've had a front row seat of this. We're also an employer. We've seen our own employees impacted by COVID. So what we're seeing is an increase of the utilization and the types of care that's missed. So we see that positive path forward and changes to catch up on it, but there's still areas we need to address. So when we look back at social determinants of health and how they impacted that delay, it's important to look at the specific types of care that was missed when we look at the types of solutions, which we're going to go through what those are. In this next section, we're going to review how to start the process for creating an inclusive medical plan. Now, this level of covered member measurements is really emerging practice. I did hear back from your community that many of you actually were doing this and already sourced it. So I will try to be brief when I go through this because I do know that some are really starting down this path. So some of this information is easier to track and measure than others. So here are a few options. So the purpose is to ID the gaps by combining that employee data with social determinants of health data. So what this does is it's going to focus on kind of your pooled memberships areas to focus on. So the types of data, right? Internal resources. Internal means those that you're covering under those employers. So it's often in their HRIS systems or EEOC data, medical plans. If you're not able to really access that first part of that data, the important part and kind of the key component is your medical plan data, which I know you guys see annually, but let's talk about the points of that. So for external, this is an area that it isn't always kind of prevalent in what you get to see for data every year. But what you're looking at is that community health data that you're applying to where your populations live. Where you can find this is the CDC, Census Data, Agency for Healthcare and Research. You can type in a zip code and it will tell you everything about that location, specific demographics, household income, prevalence of disease state. So based on the feedback that I've heard is a lot of groups are already outsourcing this or plan to outsource this. I've seen lots of different presentations on groups that do this very well. So certainly that's going to be based on your budget and really what steps you can take. But the purpose of pulling this all together is highlighting those opportunities and those areas. So let's touch on a couple of those data points. So for the HRIS EEOC type of report, you're looking at the demographics of your population, their salary, what's their income there as an employee, the geography, where are they living? I think many of yours are regional and not necessarily spread across the United States, but you're going to see their dependents are living across the states, maybe in college towns that you'll see. Their education, what health plan coverage they take, and the cost of their benefits in association to their salary. So for the medical plan data, which I know you see every year, but what you're looking for is when the utilization, what types of services are they having or not having? And then gaps, which I'll call gaps, geography gaps as care deserts, where there's just no access. So you're looking for a lack of not just where there's no care, but maybe specifically if there's something really lacking that you could add, which we'll go through kind of what those are. So for external, these are the types of external data that you're looking for. So access to care that's based on kind of where they're living, prevalence of chronic conditions. Those are different across the United States and where they live. It could be heart disease could be number one, or cancer can be number one based on that geography. The ages of the area, gender, race, and household income is definitely a big takeaway from the area because you can do the analysis of, is my plan affordable? It's how you do the math. If anybody wants to reach out to me on how you say, do I have an affordable plan? We can certainly dive into that. So now that you have the guidelines, here's an example of what you're looking for. So I pulled a list of chronic conditions with known racial and ethnic disparities. So when you look at this, one important thing to think about is, does this line up with your data? Or do you have an outlier? And outliers are important. So it depends often on the industry and location of your employees. I'll give you two examples of, we work with several of the tribes in Arizona, and their needs are completely different, living on the outskirts of Phoenix and Scottsdale, than our urban partners. We also have a partner in a rural area in Nevada that actually doesn't have any specialty care services within 100 miles of their location. So their needs are very different. So when you're looking at this, the data is going to identify those patterns and areas to focus on to make those plan changes. So when you're merging this now, what are we doing next? So actionable insights that you have, the tools that you have to be able to take those next steps, right? You're identifying the who is at risk. Then you're going to understand the how those vary between the communities that your members live and work. And then the cost, the utilization and the impact of certain conditions. You're going to see that in your top 10, your top 3, and then you're also going to find any outliers that you may need to address. And then you're also going to understand the attitudes, lifestyles, how your employees are using their plan based on kind of what their needs are, where they live, their income. You're going to see all of that. And so the next step is to develop those programs, how you implement them within your medical plan. So for this last section, I will talk through the specific plan design considerations. So let's start with costs, which is often on everybody's mind when you're looking at different costs of the plans and your actuary is looking at it, the financial impact every year. So what your pool members really are impacting. So it's important to offer affordable coverage. We've discussed that. And looking at that household income and the percent of the cost for the members. And why that's important is to ensure that you have multiple different plan levels. So Mayo Clinic, we have 3 levels. One I call it's pay now versus paying later. So highest premium, the lowest out of pocket. And then we have what I call is really a bronze plan. So very low premium and then a higher out of pocket partner with that HSA. So that's really meeting all levels of our employees where regardless of what you make, you can take a plan that fits your needs. Second is that network coverage, which is coming with your plan. So is there any need that you have for what I'll call a wrap network, where if you've picked a local network that has a really narrow coverage, how are you going to meet the needs of anybody that is not right in that area? And I'll just share that this is something that Mayo Clinic is presented with right now. 3 years ago, 10,000 of our employees went home. And 10,000 of those employees are staying home. So that's our shared services. So finance, human resources, marketing, public affairs, all went home. And so what we're finding is now for the first time ever, we can live wherever we want to live. We don't have to be close to one of our centers. Well, our network is designed around living next to one of our main centers. So our plan is really working against us at this point. So we're evaluating, one, where did everyone move? And even in a community, I do live in Jacksonville, Florida. It's a huge city. So if I live an hour away from campus, I'm not driving into work where I could have gotten my primary care. So we need to ensure that we have a community that can serve that population now. So we're currently in the process of that, looking at national wraps and how to really expand that network. So third is preventive screenings. So when we go through preventive screenings, this is where it's important to focus on specific types of preventive screening. So one starts with primary care, of course, having that access to primary care, whether that's in person, on site, near site, or even virtual services are going to help them get the orders in for those labs, types of exams that they need also. The one partner I mentioned that doesn't have any specialty services within 100 miles, what they did is they have on-site clinic. They actually have 2, and it's in a manufacturing type of area. So they have one that's on campus that's just for employees. And then they have another one in the local area. And what they've done is they've opened it. So it's not just the employees that they serve, they also serve the dependents. And they've added in multiple layers of mental health services, physical therapy, medication management. So they've really met the needs of those employees by adding additional services directly to that population. So when you look at those type of things, so for specific types of care, I'll give you an example of for breast and cervical cancer. So there was an 87% drop in breast cancer screenings in the last 3 years. There was an 84% drop in cervical cancer screenings in the last 3 years. So when you compare that back, the leading cause of death in Black women is breast cancer. They're 2 times as likely to be diagnosed compared to white women, and they have 3 times the mortality. These are specific types of services that you can focus on. I'm going to share a couple of examples of actually what Mayo Clinic is doing and some other opportunities. So community partnerships. This is where you're partnering either with a local provider or one, as I mentioned, that either you have on site or even a vendor that'll come in for evenings or weekend, different type of opportunities to really help you address and develop different access for your employees in need. So what do those type of interventions look like when you have that partnership? So for interventions, there's several, and I know I've listed many here. And the reason is the studies have shown that using a multi-component intervention, it's going to lead to a greater results in participation because everyone has different needs. So when I see reminders on that first one, we've all gotten that postcard that it's open enrollment. So when we talk about reminders, it's not just a postcard. It's letters, it is the postcards, which I love postcards. It's emails, it's phone messages. So not just letting them know, hey, it's open enrollment every year. It's you're due for your screenings. So your partner in that is often you're working with your payer and your broker consultant to really gather that data, but then include in that communication direct links to the education, the group sessions or one-on-one. And one thing that we also find really advantageous based on kind of where individuals are living is offering different languages for those sessions. So for Spanish speaking languages in Arizona, we offer those sessions in Spanish, and that's really increasing the participation. Also for that educational share, I've done this before, is we go in and we speak to the third shift. So we meet them where they're at, right? They're there 7 to 7 at night. We need to bring the education to them while they're on the campus for those individuals. So then the next is consider reducing the out-of-pocket. I know this can be a little controversial, but when I say reducing out-of-pocket, yes, we know that the ACA is requiring us to cover certain preventive screenings, but there's something to keep in mind with that is, for example, 50% of women have dense breast tissue. So for individuals that know that, they know that they often have additional screening because of that. So you have your annual mammogram, you know that's covered after age 40, but now I've got to go in and I've got to get an ultrasound or even additional like an MBI. And that is a cost that we know that we're going to have in addition. So that creates sometimes a behavior where we're maybe completely avoiding mammograms because we know what the next step is, or patients are doing the annual, but not the next step. So when considering to lower the out-of-pocket for those specific kind of next steps, is something they'll ensure that they have that additional screening. And then it's not really late in the stage that anything is identified. So for incentives, I did hear a lot of feedback on incentives recently, and I was glad to hear that incentives are coming back and they're partnered with the wellness programs. So incentives that we've done in the past is based on what screening you're doing and activities, we've either reduced the premiums based on that or we've funded their health savings account. So different options there. So the assisting with scheduling, this is something can be very effective. If you're reaching out or calling or within your communications, you have a link to schedule now. This is, a lot of people don't want to talk on the phone anymore. So if you get that email, they just want to click the link and schedule now. That's definitely a nice extra step. So extended hours. So I'll share, this is something we're doing now for our employees. Yes, we have primary care centers. And the nice thing that's been great about that is they're off our campuses a bit. So while the pandemic has been hitting the main locations, on the weekends, we're supporting our employees by kind of making it fun. It's a little bit of a trickery to the kids, as we call it, boo the flu or catch up, which is a kind of a picnic barbecue type of situation. So while they're there trick or treating, and the physicians are dressed up in costume, we're going to get everything we can while they're there. So that's catching them up on all their immunizations and any well visits that they are. And then while the parents are there, we have out in the lobby our occupational health services giving them any of their immunizations or flu shots or anything that they need. So we've made it fun. Our physicians have been always willing to come in and do that extra step. So we are doing it on the weekend. You can find providers that'll partner with this because they want to see them catch up as much as possible also, so that you don't have illnesses later on. So while we're looking at that, something to add in is childcare. So we also need to have our screening as members, right? So childcare on site there so that the parent can go in and have an exam if they need to have an exam. And then again, with the translation services, that's very important because you want your community of members to feel comfortable in having that care. So let's review a couple other items. And this is kind of the comprehensive list of things that you can add in. So we're looking through 4 different steps here. And this is a strong ecosystem of providers when you're looking at kind of what am I going to do next? So primary care, we talked about that. Virtual is definitely something that members have enjoyed across the United States. It's not going anywhere, which is great. Glad to see that's covered within our payers and our networks. And for specialty and new labs. So that's ensuring that your network has specialty care services. So when primary care diagnose something, where are they going in their local community for that next step? And then I'm adding 2 here that we haven't talked about, and I'll do these briefly. Case management, it can be done so many different ways. There's navigation groups. Sometimes it's with your payer, and that works well. There's different levels within your payers. Really the takeaway of case management is how important it is. So just kind of your everyday case management where they might know they need transplant services. We're talking about going as far as early detection within your claims data, or even offering the opportunity for your employees to call in for services before that claims data is hit. So they've had that screening, they know that they've been identified as having a cancer diagnosis. You're not going to know the claims data until 3-4 months after that. So they can support those members early on or do outreach to them if they found them within the claims data. So they're finding your members, ensuring they have the services that they need. Then lastly is centers of excellence. I've listed a couple of options here. So with centers of excellence, yes, Mayo Clinic is one of the largest centers of excellence providers in the United States, but we're not just talking about the ones that are within your payer for transplant and kind of where they're directing them. We're talking about another level to direct really those complex conditions, right? The cancer that can't be treated locally, the really rare cancers, the undiagnosed that you'll see in your claims data where they've kind of bounced through the medical system with no diagnosis and just the plan dollars are going up and up and up, but also they might be on a medication that's not the accurate diagnosis. I'll use MS, for example, and the percent of MS that's, incorrectly diagnosed and they're on those very expensive medications. So we're talking about the 1% of your population that's driving that 80% of your plan dollars. So what centers of excellence do is it democratizes that access for your employees. So not just social determinants of health, so regardless where you live, what you make, and who you are. They typically remove barriers. And what that means is they offer travel for the patient and the caregiver. And if you can, depending on the types of plans that you have, they remove the financial barriers, which means they waive the deductible and co-insurance. Honestly, with members that are struggling with these types of diagnoses, have already hit their deductible and co-insurance, but if it happens to be January, then it is important to remove those barriers regardless of where they are. So let's take a high-level review and a look at what does this look like from a patient's perspective if they're participating in those last 2 options. So in this example, this is what it looks like at Mayo Clinic. So we're collaborating, or you're collaborating with somebody that's overseeing those pooling with a service partner. That service partner can be your payer's case management or a standalone kind of navigation concierge service. They're identifying that partner either through claims data or self referrals. But so that you're not opening the door wide open, right, for anybody that wants to call, there is a screening process when you're referring the member in. So the records are evaluated. So you see the funnel there. The records are evaluated to really say, can Mayo Clinic make a difference in this patient's care? And if it's no, that their treatment plan looks good, we're going to say continue your care locally and stay in your market there. If yes, we feel like there is something that we can offer that's really differentiated than what the local market can offer, then we're going to recommend traveling to Mayo Clinic. And from there, it's really holding their hands with scheduling, also offering travel services. They're on our campuses, depending, I'll just use cancer diagnosis, typically 3 to 5 days. And then we're sending them back to the local community where they have their support system for any ongoing care. So with that, in our closing session here, a couple key takeaways that we've gone through of really disparities, what those are, identifying the areas of opportunities in your offerings and where you can make those change, and the programs that you can create, and the couple of examples that I gave. And then the importance of collaborating with your vendors and partners that you can implement those enhancements to those programs that you identified. So creating that inclusive medical plan will address your organizational goals and the health of all of your members. With that, I'll close this out. I do have my link here to my LinkedIn if you'd like to connect with me. I'm one of the only Dana Bakers actually in the system, so feel free to connect. Thank you for attending today. I really appreciate your time.